And then we will restart the meeting on agenda item 53. Welcome back. Agenda item 53. With the preparation, over to you, Scott, to introduce the paper.
Thank you, Chair. So an important paper that comes at this time every year. This is on behalf of Helen, Lynn and I, and that's important in that it seeks to balance access over winter by keeping us safe and of a good quality and using our resources well. We know that the pressures increase over winter, that's well known. Paradoxically, we know that attendances at hospital tend to reduce, but the patients that do come tend to be sicker. And we then see, of course, respiratory illness, sometimes seasonal winter viruses, and that compromise not only our patients but our staff. So the three layers that are well rehearsed, there's our day and daily operational rhythm under the operational pressures framework, the OPAL score, as you'll know. We've also got our ongoing urgent care improvement work, some of which I referenced earlier, and we'll augment that this year with the urgent care GIRFT work. And we've got our bespoke seasonal winter plan, which is what this paper describes. We don't receive additional or external funding for winter, and this paper is in that context. You'll see on page 227 the goals of this plan, which predominantly are about keeping safe and high quality access. Some of the subsets of that are in category 2 ambulance wait times and our contribution to those. The new 45-minute ambulance handover times, of course, the 78% 4-hour access, the number of patients we have in delay, and some bespoke things around how we deal with children and young people over this period. We make the point, as you'd expect, in paragraph 9 around the autumn vaccination programme, and with Lynn and Ali's leadership, that starts in Bangor soon. And there's national advice and guidance for that. The detail of the paper is on the table that starts at page 228. We don't have a bed-based plan for RLI. This year, we made changes last year where we changed our frailty arrangements in terms of the frailty same-day emergency care and the acute frailty unit. We have a very small number of beds that we will escalate at Furness General Hospital, and some of the funding will point towards that. You see in detail, both at senior and resident doctor level, the additional medical workforce that will service InReach additionally into the emergency department over the weekends and in the out-of-hours period. You'll see that also extends to paediatrics, both sites, which is a welcome development. You'll see in 3 on page 229 the things we're doing to hold the position that I described earlier on the improvement in ambulance handover delays and give that as much resilience as we can over the seasonal winter. The diagnostic capacity you see in row 6. As I said, when we get to the risk section, this is a balance of resources that we get no additionality for and keeping us safe over a period of seasonal winter. And so ideally, I would want this to deploy this plan for 3 months. Particularly, we know that March can be one of our busier months, but I wouldn't be satisfied deploying it for February and March. We need to start it at the start of January. So we therefore take the pragmatic decision to deploy it for January and February. The risks obviously should include the chronic issue around not meeting criteria to reside, and we are beholden to plans from our place partners and local authority partners on what additionality they may provide over the seasonal winter. The point 18 is important. We are a trust who does not take down elective capacity over winter. and we're proud of that. We're keen to hold that position. There's as much, if not more, risk in that elective cohort of patients than there is in the undifferentiated urgent care patients, and cancelling electives is not something that we would be wanting to do as a trust. The rules for that change slightly should we get to the rare event of being an Opal 4, but even then it's not an automatic that we will be seeking to take down any elective activity, and I'd want to hold that position. And it mentions at paragraph 21 that the cost of the winter plan for 24-25 was £490,000 for the 8 weeks. The previous year that was near £800,000. You'll see in paragraph 20 that the plan described here to do this for 2 months has a price tag of around £525,000. We don't believe in the balance of risk and resource that a spend of £740,000 for it to extend for 3 months is the right balance. And so the board's asked to approve that plan, approve the understanding of the resources, and accept that ideally we would deploy this over 3 months, but this is us balancing risk and resource. And I'll come to the second half of this paper. Keen to stop at this point for any questions or comments, Chair.
Any questions? Mike?
I've got one. Just the additional medical workforce at RLI and FGH, the Kendal UTC and the acuity changes that we're seeing in there. Has that been factored in at all into this winter plan?
It's not, Mike, for seasonal winter, and you're absolutely right. We are increasingly thoughtful about the acuity that we see at Kendal UTC, and in fact we met as an exec team with the clinical lead for the Kendal UTC last month to discuss exactly that. So we've got some plans for that in business as usual. The reason for the inReach in the seasonal winter plan is for the front doors that are open 24/7, so that we've got senior and junior doctor resource to inReach to patients who have got a decision to admit. Those patients aren't in the UTC, they're in FGH and RLI ED.
Right, okay. So if somebody appears at here, then just it would be normal business as usual. They just do it anyway. So.
For the purposes of the seasonal winter plan, yeah.
Thank you. Karen?
Oh, thank you. Thanks, Scott. Just a couple of questions. Is in terms of risk, is it too early, or would it be revisited to consider the potential risk that we've just highlighted today around workforce, just around the kind of increasing disaffection, sickness, absence, and just the accuracy data around that as a potential risk? And the second one is the potential risk of any industrial action across the winter period. Is there a point at which they would be factored in when they became better known?
Thanks, Karen. To the second one, absolutely. We're not at this point cited or any specific industrial action, but I think certainly should that be the case over that period, then we'd respond as we have done well over time. It may certainly, if we were at our most pressured and there was in parallel industrial action with that, clearly that would increase our risk. So we may seek to amend this plan, but we'd be quite agile about that depending on the nature of the action. To the first point, it's a very good point. I was going to say actually in my summing up and didn't, so thank you. What this paper functionally, I guess, describes the plan. What it doesn't do is describe the importance of looking after our staff over this period. It's a tough period. It's a tough time of year. It's dark, and we're right at the peak of our pressure on a pretty chronic baseline of urgent care pressure. So certainly from the exec team, the divisional teams, then the importance of our visibility, care and support for colleagues out there will be really, really important. If we do see spikes as we did last year, I could think of 2 areas where we saw spikes in distress over that period, and then we heard those and we responded. I remember personally being in one of those departments with Tabitha last year, just meeting with staff, talking to staff. I know the divisional teams did the same, so we'll certainly have a weather eye to that over that period.
Thank you.
Sarah.
Thank you. Actually, because I know Tony's got a question as well. Is it all right if Tony goes before them?
Yeah, fine.
Thank you. I should have raised this at the Finance Committee, but I did, Scott, and I think it's in like the TIB, the Transformation Improvement Board meeting. Just how does this read across the context of this with the Transformation Improvement Plan, the reconfigurations and the criteria to reside? Because in my head, I see there's a correlation or a relationship between capacity, demand, and beds and the work that's been done.
In direct relation, I suppose there's two domains, Tony. The obviously the should we accelerate the improvements in not meeting criteria to reside, that of course will de-risk some of this situation. I guess on the flip side, if we know that if we reach a trigger for not meeting criteria to reside that we sustain a reduced number, then our plan would be to commission some bed base. So of course you'd be seeing on one hand, but a period of increased urgent care pressure, and yet we'll be looking to decrease the bed base. So we'll balance that based on risk. It's particularly Lynn's Helen's kind of clinical counsel on that. So they are related. I think we would see a transient upside if we saw NMC2R reduce. We may then have decisions to make based on risk around the size of the bed base if we saw those improvements made.
Okay, thank you. Thanks, Sarah.
Thank you. I wasn't sure if that was going to answer all of my questions, but it didn't, so that's fine. I've got two questions actually, Scott. Thank you. I think it's a good paper. It's really helpful. I know last year we talked a bit about did we articulate the risk, and I think this has addressed that, and as well as the other programmes of work that are ongoing. So I think that's really positive. One of the things is I guess a concern for me, which is there's a commitment to restore capacity on the ED corridor to a maximum of 10 patients with a registered nurse. And the question is from what to 10, and then just mindful in particular of CQC comments from the recent visit, and just thinking about the quality and safety and patient experience for those patients and their families. Can we be assured that in doing that we can maintain those things for those patients who would reside in that corridor for a period of time?
So we'd want to see that the appropriate staffing model, if that's the decision that we had to take to increase the capacity, it's not what we'd want to do. I haven't seen that staffing model in the plan. I'm assuming that's one of the divisional plans to make sure we've got the appropriate staffing.
Yeah.
I don't know that answers to your question.
So what is it currently? Because we're saying it's going to be restored to
8, yeah.
So we're adding 2. Okay. So I suppose if I could ask for that assurance that Lynn is, comfortable with that staffing model, and therefore the quality for the experience for patients, that would be really helpful if that's okay. And is that related as well?
Yeah.
Yeah.
So the other thing to say is, as Scott has mentioned, around the UEC Further Faster GIRFT programme, which will look at the sort of 3 programmes of work that we'll be working on. One of the 4 metrics is to do with decision to admit 12 hours, and also to look at the reduction in use of temporary escalation space. So it is one of the metrics in terms of outcomes that are going to be looked at as part of the changes to be made.
Okay, great. Thank you. That's really helpful. My second question relates to finance. So you've noted that there's no additional funding, and I know that we thought that was the case last year, and then I think did we receive funding? We didn't receive any. Okay. So is the 525,000 within this proposal already budgeted for and allowed for within our deficit? And then I think my follow-up question to that is, should we be moving to a point where for next year's planning it's included in our planning so it doesn't come through as an sort of additional pressure, not ask or pressure, if you like, within that deficit?
To answer your first question, yes, it is included in our forecast out figures that we're going to have talked about today. And secondly, it is in our annual budget, so it was in the annual budget paper. I think we bring it here just as a reminder to colleagues that actually we've been through a process to review the plan, ensure that the costs are appropriate and that clinical and operational colleagues are aligned as well.
All right, thank you.
Susie, do you?
Just a very quick question. You've extended it in that month, so it's going to be March as well.
No, it's not. So it's going to be January and February.
Right. Okay.
So ideally, we would seek to deploy this for January to March. But I guess the in balancing resources, equal quality and access, then our recommended position is that we do it for 2 months.
Right. No, because I just noted that Easter is first weekend in April.
Yes.
Presumably that affects our staff and visitor influx. So,
does.
but that's going to be outside the account.
Great. If there are no further points, as Scott outlined, the ask is to approve the seasonal winter plan, and in doing so, approve the resourcing of the winter plan from Trust Resources up to a maximum expenditure of 525,000 over 2 months. The 3 month option has been considered but isn't financially viable at a cost of 740,000, and to review and approve the NHS England board assurance template. Are we all happy?
Yes.
We are.
And coming to the template, Chair, thank you. So this is a new ask of NHS England. It's actually a helpful, I guess, checklist that the board would want to consider. And it's to be signed off pending discussion at board by the Chief Executive and Chair. The things that are brought to your attention, if you look down the middle column for the yeses and nos, on page 235, the no relating to the regionally led winter exercise says no there, which was accurate at the time it was written. That meeting is today, and colleagues from the urgent care team are there today, so that will turn to a yes today. The things that say TBC following the board, though, that's what we're doing right now in terms of the plan's content, so that's to confirm that it's been here. And then when we get into section B, you'll see there a comprehensive in the rightmost column summary of why the answers to the questions are yes. So it's asking the board to actively consider this checklist and ask, is it content that we submit the board assurance template relating to seasonal winter?
Everybody? Aaron?
Yes, content with the statement, Chair. I think one of the points Scott reflected on in the introduction of the paper was the reliance that we have on partners in terms of that whole system approach to managing urgent care pathways. So this could feel quite exposing that a board's kind of signing up to something that actually we don't have all of the parameters of control to ensure safe and effective urgent care delivery over this period. So it's very specifically about the areas that we are accountable and responsible for and having due consideration for that. I think the reflection then as we look to the next phase of planning is ensuring things like demand management, consumption reduction feature in the next round of commissioning and provider conversation. So we have less of this kind of conversation at separate boards at this time of the year, every year around what are you doing about winter then and how are you signing off that you're comfortable with it. I definitely think there's a better way of facilitating a conversation around urgent care per se, not just winter with partners, which I'm keen to explore further in future role.
Yeah.
Great. Mike?
Really quick one. Page 235, Scott, are you going to continue just to identify the executive accountable? Because it says chief operating officer.
It will be the chief operating officer. Yeah, it will be, yeah.
Thank you. Thank you. Thank you. If everybody is happy, we will move on to item 54, which is the biannual nursing, midwifery and allied health professionals staffing update. Can I turn to Lynn to introduce?
So as you said, this is our biannual staffing report. It's a statutory report that we have to do. Lorna Pritz online and is going to present the report. She leads this piece of work.
Morning, everyone. Thank you for asking me to present the paper, and I'll take it as read if that's okay. I just would like to highlight a few things from the paper. Firstly, that there are no additional staffing asks in terms of establishment as part of this staffing paper. The first figure, which is a new addition to the paper this for this time, highlights the acuity levels of the patients over the last 3 data collection periods. Interestingly, it does highlight a trend of an increase in the 1B patients, which is our more dependent patients, and a reduction in level 0 patients, which are kind of our baseline hospitalised patients. We think this may be connected to our numbers of patients not meeting criteria to reside in our hospitals, and obviously it does impact on the skill and staffing requirements for those units and departments. It increases the need for staffing, basically. So we'll do further exploratory work on that and bring further detail to the next report. I think I'd like to highlight as well the development of our new clinical service workforce review toolkit, which we have linked in the paper. Again, we anticipate being able to bring you the initial findings of reviews by the divisions for, in particular, advanced clinical practice, clinical nurse specialist and small team colleagues. Historically, there is no national tools that we can use for these reviews of staffing. So we've developed this kit to support colleagues to do something in a structured way that supports the national quality best practice guidance. Just to note the data that we've submitted, we've included some Northwest benchmarking data, and absence figures and turnover figures are positive. I think from a trust perspective, we're performing in the top quartiles. The concern really is around vacancy rates, and in particular support worker vacancy rates, which we've included in this report, just because they were significantly triggering to us. We have got some pieces of work to try and support our support worker vacancy rates. In particular, we've done some recruitment events targeted at both our main sites, which have been very successful. And then we're also hoping to launch with partners in local colleges in both Lancaster and Barrow, a clinical apprenticeship for support workers. And we hope to have colleagues starting in that in 2026. I think they're the highlights, but happy to take any questions. Thank you.
Thank you, Lorna. Alex, not wanting to put you on the spot. Is there anything you'd like to add?
No, I think we've got some challenges around specific AHP professions, in particular occupational therapy at the moment. So I'm working alongside obviously the division, but also Jamie Sweet out in place, just to look at how we can look at mapping the therapy services in particular from an HP perspective, and then we'll move on to imaging radiographers in the next phase as well.
Good, thank you. Sarah.
Thank you. To confirm, first of all, we did receive it and consider it at Quality Assurance Committee. We were assured by the lower levels of harm and incidents with no correlation to staffing levels. Is that what you right? Sorry. And also obviously that there's no request for workforce uplift, which is reassuring, and we thought that was a really positive performance in terms of balancing quality and safety with financial workforce requests. I did want to highlight though that on page 247, which is figure 14 in the pack, and figure 2, which is the graph or the sort of dashboard on that page, there's a lot of reds on there which relates to community staffing, and what we were reassured that the community nursing teams are confident and comfortable with their levels of staffing, but less assured really by the number of reds on there, and we're concerned that that might come at a cost to staff who are perhaps carrying heavier workloads than perhaps we would be expecting, and we did ask for some additional assurance really around staff wellbeing related to that.
Just a wider point around the community safe staffing. At the moment, it feels separate to the work that we're doing corporately. So there's going to be a plan to move that into with corporate oversight. I think there's a lot more understanding needs to be done about the community staffing model, because it's not quite as clear as other staffing models.
Yeah, thank you. And we are also looking forward to receiving reports around AHP staffing as and when that's developed as well. That was something we discussed last time it came to the committee.
Karen.
Oh, thank you. And thanks, Lorna. You'll know, as a previous AHP myself, I'm always really interested in the AHP element of this. And this is really just an offer. I'm aware that there are other organisations in the system that have developed really strong approaches to reporting around safer staffing for AHPs. And I'm more than happy if it's helpful to me, Lorna and Alex, just to share that. I'm really happy to do that rather than the potential of starting from scratch.
I can see lots of nods. Oh, and a heart.
Okay, we'll do that.
Excellent. Any further questions? If not, and we're all happy with the recommendations, we'll turn to item 55, inclusion reporting, and I'll turn to the Chief People Officer, Sally.
Thank you. And Carolyn, who's our Head of Colleague Experience, is going to take us through the report. But just to be aware from the request for us from a board perspective today is that we seek support to publish the annual equality reporting, inclusion reporting, to comply with the National Public Sector Equality Duty.
Thank you. Welcome, Carolyn.
Thank you, Chair. Thank you, Ali. So I'm just going to share some headlines with you today and then some key actions we're taking forward. This is probably our fourth discussion on these results. I'm just going to share a couple of slides. We had a really good discussion at People Committee last month. So we have been working on the results and also the action plans as we've worked through all these discussions with various stakeholder groups and governance steps. So I just want to cover the current position from a workforce race equality perspective, and I'm trusting that everyone can see slides. I've lost sight of you all now because I've got you on two different screens. In terms of RES, we have seen some really pleasing sustained improvement, which is over a 3-year period. So on bullying and harassment, we are seeing a continued slight.
You can't
Sorry.
see the slides.
Oh, apologies. Okay. Let me try that again. Can you see them now?
No, I'll go to the.
No. We're seeing from just our end.
I can see them remotely.
Okay.
Maybe in the room. Carolyn, if you continue, they've appeared. It's sorted.
Oh, fab.
Continue.
Thank you. Okay. So we have seen a slight improvement. We would like to see further improvement on this, but the good news is that is being sustained. So we're seeing slight improvements year on year for the last 3 years. So drops in BAME staff experiencing bullying and harassment from colleagues. We've seen a sustained improvement in terms of this colleague group feeling that career progression is fair at the Trust. So this has gone up quite considerably since 2023. And we have seen a good sustained drop in staff experiencing discrimination from other staff. That's down from 22.4% in 2023 to 16.8% this year. Obviously, we still want that to keep decreasing, but it's pleasing to see a steady progress on that. Areas of concern for us with the RES are recruitment. Despite our diverse panels being reinstated this year and all the work we're doing around inclusive recruitment, we are still seeing a higher likelihood of white staff being appointed after shortlisting, and this is a worsening trend over 3 years. So this is something we really need to understand more about, and we are taking steps to do this, and you'll see in the actions at the end, the activity will be really focusing on over the next year. In terms of disciplinary process, we've still got some concerns around BAME staff being twice as likely to enter formal disciplinary compared to white staff. We are above the national average for this, and this is despite us having introduced our employee relations triage. So it's important to note that we have seen improvement since the introduction of that triage panel, which really fully considers all aspects of a colleague's situation before progressing to formal disciplinary, and involves an inclusion team member being part of that panel. However, we are not yet cracking it in terms of we'd really like there to be no disparity between those two groups. So that's something we'll be reviewing and doing further work on. We've got some concerns around equality to training access. We do see that white staff are more likely to access our non-mandatory training, so we need to look at how we can influence that. We do think there may have been some impact in our training pause that we were experiencing last year. However, we now need to ensure that managers are really being thoughtful about how they ensure equal access across all colleague groups to non-mandatory training. And we still see an underrepresentation of our BAME staff above band 5 in agenda for change roles. So that's something that we do really need to understand more about. And that fits quite well in terms of fair and inclusive recruitment aims to really ensure that we are looking at removing that ceiling there for those colleagues. Moving on to our Workforce Disability Equality Standard. We have had our highest ever recorded representation of colleagues identifying as disabled. This is following a campaign we ran to really encourage people to declare their protected characteristic status on ESR. So we're pleased to see that. We are also seeing equal likelihood of appointment for disabled colleagues compared to non-disabled colleagues. And we haven't seen any disabled staff enter the formal disciplinary process in the last year, or indeed since 2021. However, there are some concerning statistics for this colleague group. There's a high demand on colleagues feeling pressurised to come into work when unwell. This remains unchanged from last year, so that's over a quarter of disabled staff. So we do really need to understand more about that. And we have seen a reduction. So this is in comparison to the race equality piece. We've seen a reduction in or an increase in disabled staff experiencing bullying and harassment from all three groups: patient service users, managers and colleagues. So that's a real area of concern for us, because that colleague group is experiencing something quite different, and that is worsening for them in comparison to other colleagues from different ethnic minority backgrounds. And overall, there was a reduction in colleagues feeling, quite a significant reduction in disabled colleagues feeling valued by the organisation, which is something we really need to understand more about. Moving on to the Workforce Sexual Orientation Equality Standard. Again, we have equal likelihood of appointment, which is really pleasing to see, and that's being sustained. And we haven't seen any LGBT plus staff enter formal disciplinary in the last year. So they're actually in a positive equity position compared to non-LGBT plus staff. However, we are seeing similar themes to disabled colleagues around bullying and harassment. And you'll see, particularly for bisexual staff, they're reporting considerably higher rates of bullying from colleagues, much higher than heterosexual peers. So that's an area of concern for us. We also are still really struggling to get good data on our trans colleagues, which really is representative of a lack of trust. And this might be being influenced by the wider media dynamics playing out for this group, but it's really concerning to see that we still don't have any colleagues who are declaring their trans status within our staff survey, which means that we really don't know what the lived experience is like for this group in our organisation currently, and that's been the position for quite some time now. So moving towards action plan priorities in response to this data for 25-26. In terms of zero hate, we launched a zero hate policy earlier this year with a campaign, and we can see that all of our colleague groups are experiencing higher levels of hate incidents from patients and service users. So this is a really key part of our work in the year ahead of us, to make sure that our teams who experience this understand the policy, that they understand what steps to take if they're experiencing this, that colleagues understand how to support their colleagues who are experiencing this. And we're going to be using a data-led approach to look at which teams are experiencing the highest level of hate incidences to ensure that we're getting bespoke and responsive support into them from our inclusion team and our staff network colleagues as well. We're going to look at how we sustain our increase in access to reasonable adjustments, and also provide a stronger framework for managers who are struggling to navigate balancing reasonable adjustments, because often this is becoming an issue for managers, that they've got a series of reasonable adjustments across the team and they need to take decisions to balance that against the service needs. So we'll be looking at establishing a reasonable adjustments panel, which provides additional guidance to managers and colleagues who are unable to agree on a position on reasonable adjustments. And we will also be looking at additional guidance for access to work. This is a national initiative that supports colleagues to stay in work, but it's quite a difficult process to navigate. So we'll be looking at how we can ease that for managers and colleagues. We're expanding our education and training offer on neurodiversity, mental health and disability, and how they impact working lives to help managers and colleagues understand how they can better support colleagues affected by a range of conditions. And we're also doing similar with our LGBTQ training offer in order to build awareness of these issues. We took steps already this year to really increase our LGBTQ awareness sessions in response to the Supreme Court guidance, and we'll be looking at how we widen our listening spaces to really understand some of the parts of that community that we're not hearing from through staff survey or other routes. In response to some concerns around equity about recruitment, particularly for our BAME staff, we will be building on our inclusive recruitment approach. So we're looking to expand our use of multifaceted recruitment approaches such as assessment centres. We're going to be continuing to build our inclusive recruitment ambassador cohort so that they're well placed to sit on diverse interview panels across the organisation. And we are once again mandating diverse panels throughout the organisation to ensure fair and equitable recruitment and career progression. We're aligning our executive inclusion objectives to the areas of most need. So we've had particular focus around disability for some of our exec colleagues, and we're going to be continuing to work very closely with our networks because they're absolutely key to understanding the reality for our colleagues out and about and the lived experience to help us respond to some of arising issues, and also to help us raise awareness of issues that are affecting colleagues from different backgrounds. So I'll stop sharing there and take any questions.
Thank you, Carolyn. Nicola.
Thank you. A really comprehensive set of information and data we've got there, and I like the summary that we got from the slides. Thank you, Caroline. I was interested. One is the increase in declaration, which is really great to see, encouraging our people to feel it's okay to speak up about their special characteristics. Do we know whether that in any way correlates with the increase in poor experience, whether it's feeling pressured, not valued, treated unfairly, bullied, harassed? It's a query just to know whether there is a correlation there, because we're seeing that more generally across populations. I really liked amongst the actions that we're going to expand awareness, and I think that ties into some of the work around culture. And I think one of the things that's really important there is to think about, in some of those characteristics, it's not unusual for people to have rejection sensitivity because of what they've been exposed to whole of life. So it'd be really important that we sort of raise that awareness amongst our staff, because it does form the way in which you approach conversations with them. And then I think thirdly, do we have any plans to perhaps also do some data analysis around intersectional experiences, so where people fall into more than one of those characteristics, and whether those people are actually having an even worsened experience?
Thank you.
Thank you.
Caroline,
I'll start.
Yeah, you respond to that one, and then I've got about 3 other people who want to come in. So.
Yeah, no problem. So in terms of a correlation between declaration rates and negative experience in terms of bullying and harassment, I don't know if those two are linked, to be honest. Often we find people are less likely to declare if they feel they're at risk of being bullied and harassed, even though we do take a lot of efforts to talk about ESR confidentiality and things. But if people are having negative experience with their manager, it is less likely for them to put that declaration on ESR, because obviously managers do get some access to data, and staff are often quite unclear what level. So I don't know if it is related, if I'm quite honest. I think there is a need for us to do more listening to these groups of staff. We ran some really good listening events 2 years ago now with our disabled colleagues from the Disability Network, and from that's prompted some of the work around access to work, reasonable adjustments and things like that, because we were able to identify some real barriers to people getting the support they needed. But I think we need to understand, I think your point around rejection sensitivity is really interesting. It's something we are covering in our neurodiversity awareness training. And we do need to unpick, when people say they are being bullied and harassed and discriminated against, what is that experience looking like for them? Is it a consistent experience for all of the groups, or is it slightly different depending on where you are in the organisation? It is interesting that we're seeing the inverse for our colleagues from different ethnic minority backgrounds, because you would hope that a rising tide would take all boats with it. And so often you do see that when things start to improve for one group, the other groups experience some resulting improvement there, but that's not happening for us. So we need to really get in and understand more about that. But I think the key to that is going to be getting beyond the staff survey data, beyond the res and des data, and really having those conversations alongside the networks. Rejection sensitivity, as I said, very good point. We need to unpick more around that, but it is something we are talking to managers more about, and starting to, what we really want managers to think about is hidden disabilities as well. Often people don't feel confident to declare neurodiversity, for example, or they might be at the beginning of a journey understanding their own neurodiversity. So we need to be really thoughtful about what might be a possibility when you're interacting with staff. And finally, the intersection experience, we do really want to do more work on that. We are hindered by being quite a small team, but we do want to work with getting our networks together in terms of having a joint network of networks response, because I think there's a lot of value for the networks from hearing from each other, and we do see colleagues who are involved in each group also. I think it's a reasonable assumption to make that colleagues who are affected by a series of who have different protected characteristics may well be having a worse experience. And again, it's about understanding what can we do that's really meaningful to address that.
Thank you, Carolyn. I'm going to bring in two other non-exec directors, and then if you can respond to both of their points together, that would be great. So firstly, Mike.
Yeah.
Thanks, Carolyn. Mindful of time. When you presented this to the People Committee, and I may be misremembering, but there were some figures around in the res data about the abuse from patients and the public.
Yeah.
Is that? Read through this, I couldn't see that being highlighted. There's the staff issue.
Yes, apologies. That should have been on these highlights. Yeah.
Was quite a stark figure.
Yes, yeah, and apologies, it's not included in these slides. It should be in the paper that you have that, and obviously it's in the reports, but that is a real area of concern, and that's why we really need to focus on the Zero Hate policy and campaign, because that addresses it's a shared experience. Thank you so much, Mike, and my apologies for missing that off this slide deck, but that is a shared experience for all three protected characteristic groups, that there are increasing hate incidents against them from patients and service users. So that is something it's a national picture. We're not alone in that in Morecambe Bay, but it really emphasises the need for that zero hate approach and that confidence in our staff to use that policy and to know they'll be supported to use it.
Thank you. Tony?
Yeah, Caroline, just very briefly, great piece of work, thank you. Do you think our recruitment approaches are sufficiently diverse, both in terms of method and approach, to really attract people from different backgrounds and groups? I've talked from my own experience, it was a very linear NHS approach to get into the trust. And obviously for certain groups, there's certain periodicals, media, software, different ways of getting people involved. So I'm just asking that question. Thank you, Chair.
Thank you, Tony. Carolyn, can you hold responding to that question? Because there's two other NEDs have indicated that they want to come in. So if I can bring those two in and then you try to respond to all three at the same time, that would be beneficial. Karen.
Oh, thank you. And thanks, Mike, for raising that point about patients. Just an update to that. We agreed at the People Committee that we would do two things. Is one, we'd bring an update on the Zero Hate strategy rollout and importantly impact to the October meeting, because it's the impact that counts. So we'll be taking that at the next meeting. And the second, we also made a commitment to triangulating between the People and the Quality Committee around incidents involving patients. So it's the incident reporting. We know we have the incident reporting where this involves patients, is very clear, but also to triangulate that to make sure we're doing the same for staff. So just to assure the board that those two actions with regard to Zero Hate are going forwards.
Thank you, Karen. And then finally, Jalabani.
Yeah, good afternoon. Can I just check if you can hear me? I'm having issues with my internet.
We can hear you loud and clear.
All right. Yeah, great. My question is around more of ethnic minorities getting into formal disciplinary procedures in terms of us not performing well. Do we have comparable information from other organizations that are doing well? Is there any learning from that? I appreciate the panel has managed to help improve the position, but not in a sufficient way. So that's one. And in terms of experiences, I know we've done quite a lot of work in this field in terms of all our characteristics of staff. But is there something here that we need to focus on in terms of the themes or specific directorates or specific areas where this continues to be an issue? Previously, I'm not going to dwell into the departments, but if we can actually focus on those areas to ensure that we can see some obvious improvements.
Thank you. Caroline, if you can try and respond to the three different issues raised.
Absolutely. Thanks, all. So firstly, Tony, in terms of expansion of recruitment pathways, I think we've done a lot about how we go through that recruitment process once people have got their foot in the door by making an application. And I don't think we've done enough to look at how we attract people in the first place. I think you're right. We do very much depend upon NHS notice boards, gov.uk notice boards. And if you're not, if you're outside of the NHS and maybe you're not thinking of yourself as someone that could be part of the NHS, you're not necessarily looking in those places. So I think that is a piece of work that we need to expand out. I think where we do this well is at this very start of career. We have a lot of proactive work from our careers and apprenticeships team going out into local schools and education providers to really bring to life the opportunities we have at the Trust. They also work with local refugee groups and go and identify possible opportunities to come and join us. So I think at the start of that career pathway, we're doing a lot more, but I think it's how we bring people in the mid and later pathways. We really need to consider what approach are we taking and how do we reach a broader audience. And then moving on to, thank you, Karen, for covering those points. That's really helpful to note and hopefully some assurance to the board. And then Jalibanu, thank you so much. Yes, you're right. We do have, we can compare our data with other organisations and we do work quite closely with other trusts in our region. We haven't yet done analysis against our local trusts. We've done it nationally against the national average. So I think the next step is going to be looking at where we are with organisations we've worked with in the past to see what are they doing that's any different. The triage approach, the triage panel has had impact, but there's something about how do we take this a bit further. We are looking at also how are we as involved in the medical? The triage process covers agenda for change staff, but we haven't had that inclusion input into the medical professional standards disciplinary route. So we're looking at that as a possible place that we need to get inclusion expertise into to just ensure that we're looking at things in the round through that process also. So that's another easy step we can take, but I think there would be value in looking towards other trusts. And forgive me, I've forgotten the final point. It was around experiences and themes. Can you remind me on that one?
Ali wants to come in. She may be able to pick it up or maybe an unrelated one. But
so I was going to pick up on the disparity around the disciplinary processes. And whilst it's a very kind of binary position, isn't it, on the numbers, the key things are from this, and this is now being acknowledged nationally, that whilst there might be a disparity, it's the important bit is, are we taking people through those disciplinary processes appropriately? So are we using other means where it would be more appropriate? So if we triangulate this back with the Fair Experience for All report, what that now demonstrates is since we put all these processes in place, we have got very few cases that now progress into formal disciplinary process that then don't result in sanctions, which if you compare to previous to those triage processes being in place, we had a very high proportion of those cases that would have previously resulted in no case to answer. That's when we had the real disparity issue. So the key here isn't necessarily is there a disparity, it is if there is a disparity, are we clear about the processes that we've got into place, and are we making sure that those address the issues in terms of taking into consideration where there are other factors that should be more appropriately considered, linked to protected characteristics. that mean that we having the disparity ratio isn't necessarily a bad thing in itself. It's just a trigger for you to look into it and have a more detailed understanding. But that triangulation with fair experience for all is the important aspect.
Thank you, Ali. Jalabani, were your points responded to, or is there something you want to seek further assurance on?
Yeah, the way I responded to, I think I'll pick up some of the conversations from the people committee. It's just our staff experience, so there's a global work that we need to do to improve that. However, though, we have some pockets of areas where we need to have some concerted and focus. So my question was around that we need to bring in that focused work in areas that are challenged.
Yeah, thank you for reminding me. So this is the first year that we've actually produced divisional inclusion reports as well. Obviously, these are based on the old care groups. Going forward, they will be in the divisions, but we've mapped them across to the appropriate homes in the new structure. So that's really allowed us to look at whether there's any areas across different divisions and departments that we think are having considerably worse experience. To date, we've not noticed any areas that are distinctly different across different divisions, which I think is quite encouraging in some ways. But that will be work that continues with the division. So they're now, with our inclusion team support, they're now forming their own divisional action plans to address areas of concerns that have been identified through their kind of mini res, DES and WSOES. So that's one approach that is a step forward this year. We've never done that before, and I'm hopeful that we will see a little bit more impact from getting the actions down a level to that divisional level. And the other aspect links back to what Karen updated on, the fact that we're going to be really looking at where those hate incidents are happening across the organisation, because we do also log colleague to colleague hate incidences on the system now. So that will allow us to really get into those areas where we think that there are areas of concern and do actual really involved intervention work supported by our inclusion and OD team to get those teams into a healthier place and a safer place.
Thank you, Carolyn, for coming along today. Do I take it that the board is happy to approve the papers?
Yeah.
We are. Thank you, everyone. Very conscious of time, moving on to item 56 on the agenda, the provider collaboration update. Chief Executive.
Thanks, Chair. I'll take that as read, only to note in the update at the start of the meeting that I've now formally stood away from the provider collaborative, both from a member on the board, but also the lead CEO. So Scott will be with immediate effect, actually a representative on the provider collaborative board. Silas Nichols has been appointed by the joint committee to replace me as the lead CEO for the provider collaborative. There are updates in the report as to progress on things like the pathology collaborative, the clinical strategy, and the next phase of development for One LSC, all of which will be pulled up in future meetings.
Thank you. Sarah.
Thank you. It's just a question I would actually about this kind of board to board piece of work around the provider collaborative. We had one, was it about 18 months ago, I think. And my understanding was there was something else in the planning. I feel in terms of building a common understanding and sense of purpose, that would be really helpful. And I just wondered if there are any plans for that.
For others to take on now. So there is a conversation about the 10-year plan, the next 3-year delivery, and what needs to happen in terms of some of the policy guidance that was changing, particularly the strategic commissioning framework and the provider operating models review. So suspecting Q3 there'll be an opportunity for providers to come together and discuss that, but it'll be for others there.
Thank you. All happy to note the report? Yeah, thank you. Item 57, appraisal, revalidation and medical governance report. Helen.
Thank you, Chair. So this is just for consideration of approval prior to submission to NHS England North West, and that it has been considered by the People Committee. I'll take the report as read. A couple of areas just to highlight for the board. Over 98% of doctors completed an appraisal, and as noted, all those that hadn't, there were reasons associated with that. That we have a very healthy number of appraisers, which is not something in all trusts, so that is very, very positive in terms of that recruitment of appraisers, but also their ongoing training and support. Also, just to note, we've obviously seen around obviously some of the vacancies, including obviously medical staff, and just obviously that impact around where there are longer term vacancies, some of the challenges which are coming out in the appraisals, and obviously ongoing work on recruitment is happening. And then the last one there, just around the sort of restructure, just to reassure colleagues on the board that the Band 3 appraisal and revalidation admin support assistant has been approved and is now out for advert on track. So that has been addressed. Happy to take any questions.
Any questions for Helen on this agenda item? Sarah?
I haven't got a question, but I just wanted to acknowledge I thought it was a good report
Yeah.
actually, and so I think we're asked to approve it. So I think just the fact that I think it is a strong report helps to be able to have that assurance to approve it. So thank you.
Thank you. I'll take it back to the team. Thank you.
Great, thank you. So we're all happy to note and approve the contents of the report? Yep, great, thank you. Moving on to item 58, review of the board assurance framework. Paul?
Thank you, Chair. I'll do this in two parts because I do want to respond to Nicola's that you made in the report of the audit committee. I will take the reports as read together with the supporting board assurance framework reporting tool that we've got in the agenda for today. You can see that what we've done is to map kind of the how things have developed since the last meeting of the board of directors on the 2nd of July. We've covered each of the 6 risks. I won't go into detail because all the information is there, but just to draw the board's attention for the minutes to say that there's been no recommended changes to the scores. There is still work in flight in a number of areas, and there was a view that we couldn't begin to move to our anticipated target scores at this particular moment in time until further mitigations, assurance and controls have been delivered. And you can see the details of that in the paper. Turning to Nicola's comments, just want to say a few words about the work of the audit committee. We had a really helpful discussion around the standard operating procedure. It was a good opportunity for non-executive directors to be able to kind of reflect on the operation of the board assurance framework and whether or not it's continuing to be an effective tool for the board. In terms of background and context, for the last couple of years now, our internal auditors have been given us some very good assurance about the use of our assurance framework. It meets NHS standards and they can see that it's actively used by the board and by the assurance committees. Just to kind of summarise some of the discussions at the audit committee, some of the areas of improvement were sort of smarter objectives, clearer articulation of trajectories and timeframes and controls, and a little bit more granularity and focus in terms of the what by when in some areas. The outcome of that, though, is really just to make sure that this document continues to remain effective. So I've taken an action to commence the work that Nicola's referred to. In terms of kind of next steps, I'll share some of that work through the chair in Ned's meetings and with an executive colleagues. But I want to alert internal auditors to the work that we're doing so that when they do their phase 2 assessment of the board assurance framework next year, we can make sure that they give us an independent view of the way that we're beginning to enhance it. Just in conclusion, there's one area of the report that I just want to draw the board's attention to, Andrew, which is in relation to partnerships. So partnerships came through as a number of the discussions, and you can see there's some actions that we've set in there about in Q3, can we just refocus? We've talked about leadership changes that are taking place, what that means for the trust. There are programmes of work that have interdependencies, which we do talk about in the BAF, but for example, subject to the outcome of the deep dive tomorrow, maybe we might want to feature not meeting criteria to reside under the partnership risk as a particular area of focus. So that'll be the next focus as we go into Q3. I'll pause there, but happy to take any questions anybody's got. Andrew, thank you.
Thank you, Paul. Any questions, comments? No. If not, are we happy to, having considered the contents of the report, happy? Yeah. Good. Okay. Item 59, risk management strategy. Sarah.
So this has been seen by the Quality Committee and the Audit Committee. There were some minor amendments suggested which we've made, so it is.
Smashing. This isn't for approval. Everybody happy to approve? Great. The Board of Directors are asked to note 3 reports which have been circulated: the North West Clinical Senate report into Furness General Hospital's Level 3 Critical Care Services, the Infection Prevention Annual Report 24-25, and the Patient Relations Annual Report 24-25. Are we happy to note those 3 reports? Thank you. The attendance monitor register has been circulated. The schedule of business has been circulated. I've not been notified of any urgent business. So if we are happy with all those things, I will bring the meeting to a conclusion. The date, time and venue of the next meeting is Wednesday, the 5th of November, 9 a.m. here in the boardroom at Westmoreland General Hospital, and also on Microsoft Teams. Today's private board will begin later today at 1 o'clock, and I'm going to resolve that representatives of the press and members of the public will be excluded for the remainder of the meeting, having regard to the confidential nature of the business to be transacted. Are we all happy with that?
Absolutely.
Great. Thank you very much to everyone for attending today's public board meeting. Thank you.